Good evening and welcome. My name is Allison Leary. I'm a Newton City Councilor and a member of the 10th Middlesex Hub, and I'll be facilitating this evening's discussion. So I want to remind everyone this meeting will be recorded, and at a later date it will be public. So you can turn your camera off if you don't want to be visible. Please put all your questions and comments in the chat. And as we go along, and then the questions will be at the end. At the Q&A will be at the end, with the exception of Representative McGovern. If we don't get to your question during this time, we'll get to it at a later date. So I want to just quickly recognize our sponsors: Our Revolution Mass, Watertown Democratic Committee, Physicians for a National Health Program, Watertown Citizens for Peace, Justice, and the Environment, Our Bodies, Ourselves, and the Watertown Indivisible Progressive. I'm going to now at 7:01. I'm going to let me introduce our distinguished panel. Congressman Jim McGovern has been a long-time champion fighting for Medicare for All. As chairman of the Rules Committee, he used his power to hold the first ever congressional hearing on Medicare for All, bringing in experts from around the country, as well as those with lived experience, to talk about the need for a single-payer system. He believes that healthcare is a right, not a privilege, and is fighting for a system that puts patients first and centers human lives, not corporate greed. So please welcome Representative McGovern. We have 10 minutes to speak, Representative McGovern, and then 5 minutes for questions.
Well, I'm not going to take the full 10 minutes, but I want to thank you, Allison. I want to thank everybody on this call for your advocacy and for believing that healthcare is a fundamental human right. I'm happy to be part of this important conversation. It is no secret that our healthcare system is broken. I mean, our hospitals are overwhelmed and people can't afford basic care. People are safer and they are healthier when they have access to healthcare. I think we all know that. But the sad reality is that most Americans are one catastrophe away from not being able to afford healthcare. The truth is, it's unacceptable that in the richest country in the world, so many have to worry about whether or not they can afford basic healthcare. Over 75 million Americans rely on Medicaid for critical health services. And yet I'm serving in a body where Republicans in Congress cut Medicaid by almost $1 trillion last summer. The Affordable Care Act has been a lifeline and has made coverage accessible for millions more. The data already shows that since Republicans let the enhanced premium tax credits lapse at the end of last year, 1 in 10 enrollees have dropped their coverage. We should be investing in health. Instead, Republicans have made it their mission to make healthcare more inaccessible and more unaffordable. So this moment, I think, has woken people up to what many of us have known for a long time. We need Medicare for all. Almost 70% of Americans support a single-payer healthcare system. It is overwhelmingly popular. For too long, our healthcare systems have put profits over people. Medicare for all would put an end to that. That's why, as Allison pointed out, in 2019, I held the very first ever hearing on Medicare for All in Congress when I was the chairman of the Rules Committee. And if we can take control of this place in November, we will do another hearing on Medicare for All and work with committees to see whether we can make some progress here on the issue. But during that hearing, my friend and an ALS advocate, the late Artie Barkin, told us how he had to go use a GoFundMe page to pay for care related to his ALS diagnosis. Even the Republicans were speechless. And if that doesn't make you think that this system is going to change, I don't know what the hell would. Because the truth is that many of us really are just one diagnosis away from bankruptcy. And in the United States of America, that's unacceptable and it's unconscionable. It is not radical to say that healthcare is a human right. It is not radical to say that a person shouldn't die because they can't afford medicine. And it is not radical to say that your zip code shouldn't determine how long you live. That is why I'm a proud co-sponsor of the Medicare for All Act, which would ensure that everyone has health coverage and the benefits that they need. because no one should have to choose between getting a checkup and putting food on the table. And that's why I'm also a co-sponsor of the State-Based Universal Health Care Act, which would create a waiver granting states the ability to use federal funding to provide state-specific healthcare plans for residents that provide coverage for at least 95% of their residents within 5 years. States like Washington, Nevada, Minnesota, and Colorado are already leading the way. While we still work to achieve Medicare for all at the federal level, many states are taking the necessary steps to provide affordable and quality care. This bill would help states like Massachusetts implement a single-payer healthcare system, and it would help us create systems that are patient-centered and not driven by profits. So I'm glad to see everybody here and to know that you're committed to pursuing this effort in Massachusetts and nationwide. We may not be able to rely on Congress to do the right thing at this particular moment, but if we can make some headway at the state level, I think that's a crucial start. I believe we can get this done at the federal level. I really do. I mean, I think healthcare, when all is said and done, is a political issue. And by that, I mean that we have the money. We're investing more than enough money in our healthcare system now to pay for a Medicare for all system. We have the infrastructure. We know what to do. What we lack is the political will. I think that's going to change. And I think the days of us just talking about fixing healthcare by expanding a tax credit or nibbling around the edges, I think people want more than that. And people are impatient. And we ought to figure out ways to move forward. So I just want you to know that I appreciate what you're doing. I'm going to try to figure out ways to move the ball here at the federal level, and I'm not giving up. And so I want to thank you for having me and for being partners in this fight. We can't stop until Medicare for all is the law of the land. So I thank you and I yield back my time.
Okay. Thank you, Representative. That you really were very quick about that. So I just want to remind people to please put your questions in the chat for Representative McGovern. Representative, it seems like you might have a few minutes for questions.
I do, and what I was explaining to Allison before a lot of people got on the line is we have a little shit show going on in Congress. I think there's a more congressionally nice way to say that, but anyway, it's the only way I could describe it. Over the Farm Bill and funding for SNAP, and so the Republicans are fighting with each other right now. But we're in session and the floor is active, so I might have to leave. But anyway, I'm happy to take a few questions.
Okay. Well, I'll start with one. I mean, we've been feeling very demoralized by the harsh federal cuts to federal Medicare and Medicaid, and the other shoe will drop in 2027. Yet at the same time, I feel like there's so much more momentum for a single payer because people are frustrated by the increasing costs that are crushing municipal budgets, costing people are going to debt. It's overwhelming. And here in Massachusetts, we spend $78 billion in healthcare. We probably pay more than anywhere else in the world. So where is all our money going?
Well,
We're trying to figure that out, and I think it's part of it is the profit motive. And I'm just wondering if you have any thoughts on how Massachusetts can get from A to B.
Yeah. Well, in the short term, as we're trying to move the federal government to do the right thing, I mean, we ought to, realize that, the system is lacking, and it's lacking in the sense that if, you need open heart surgery, yeah, we're the best place in the world to get it done. But if you want to prevent from getting to the point where you need open heart surgery, we're not so good. And I do a lot of work on hunger and nutrition, and I'm a believer that we need to be more aggressive in things like food is medicine. Doctors ought to be able to give food prescriptions. We got to make sure that the meals we're giving our kids in school are nutritious, that are high quality. We ought to invest in making sure more schools have kitchens. We ought to expand farm to school programs. And we ought to have more health clinics that are also food pantries. And also, provide people the ability to learn how to cook some of these foods, which is a skill that not everybody has right now. I visited a health clinic in Revere that it's a collaboration between Mass General Brigham and the Greater Boston Food Bank They have a plant-based food pantry there, and they also have cooking classes. Bottom line is that they've documented better health outcomes for people, and they're also lowering costs. So,
Mhm.
I mean, if you want to lower costs, it shouldn't be about charging people more. I mean, if you want to control costs, it shouldn't be about charging people more or giving people less care. We ought to be thinking more out of the box about how we keep people healthier. That old saying, an ounce of prevention is worth a pound of cure. It's true. And our system is kind of ass end backwards. I mean, again, we're great at
Right.
the technical, the open heart surgery. We're not so good at preventing you from getting there.
There's a
Right.
there's,
One of the things,
there's another
go ahead.
question about whether you feel that there are any conservatives left in the Republican Party, any legislators in the party that could understand how amazing the savings, efficiency, and simplicity of a single payer plan is. Are we just at a loss with the other party? I mean, what's the story?
Yeah, I think it's, look, we have some difficulty trying to help people understand that there are cost savings here. So if you're a fiscal conservative, you should want this too. But here's what I think we need to be better at. We need to be better at telling stories, and especially about the failures of the current system. We here in Washington get lots of, papers with facts, figures, and statistics. All that is important. We need that, right? We need that, to back up our arguments. But I don't think it moves people, and it's not moving Republicans. I think what moves people are stories, and people can feel that, and and hopefully they can be influenced by that. The other thing is more pressure. If you can't persuade people through stories and through making the argument, then we ought to be a little bit tougher in terms of, saying, if you're not going to be with us, we're not going to be with you. And I think in a lot of districts, I think because of who represents them, I think some people have given up, like, he's a Republican or she's a Republican, so they're a lost cause. Well, they may be a lost cause, but I wouldn't give up on them. And the mere effort of pushing and lobbying and doing town halls and doing letters to the editor not only creates pressure, but it is informative to others in the community, who may not know a lot about Medicare for all, may not know a lot about other alternatives out there. Yeah, this is not a good moment politically, for a lot of the things we care about, but, we have to hope that things are going to get better.
Okay.
Yeah.
So is there
it
another
sounds,
question?
yeah, there's just one other question about that. It seems that you're saying that citizens have to really step up to the plate, but citizens seem to be really worried about what's going to happen in January 2027 when so much Medicaid
Mhm.
cuts are going to happen. I mean, just clinics and hospitals are sort of dreading and really feel that the cuts will really hurt their ability to provide services. What do you suggest we do about that?
So, and people have a right to be concerned about those cuts. We have to find ways to delay them at a minimum, and we have to find ways to reverse them. And that's what elections are about. I mean, we have to work to make sure we win in November. And if we can win the House and the Senate, then we're in a better position, to be able to, at a minimum, delay and then, start building the case to reverse these cuts. Let me just say this. I've been doing a number of town halls, and every once in a while, people will get up and they'll say to me, I wake up in the morning and I turn on the news, and it's not one thing, it's not two things, it's like 6 or 7 things,
Right.
and it's like overwhelming. And I'm like, and I don't even know where to begin, and I feel like I want to pull the shade and have you wake me up when it's all over. Let me just say that is a deliberate tactic, by this administration and those who support this administration, especially those in the corporate world. That is a deliberate strategy to get you to tune out, and they want you to think you have no power. I am a believer that the opposite is true. I do think people have power. We just don't use it enough, right? And, and people think that it doesn't matter. It does. It's when we're not being pressured. It's when we're not being, lobbied by citizens, when people aren't showing up, and making the case for things like Medicare for all, that's when you lose your power. And look, I don't know how all this is going to work out in the next few years, but, I've kind of resolved in my mind that I'm going to do all my best to fight like hell, that, to change the reality. Like a lot of you, I talk to people every day who are struggling. We're dealing with a farm bill that cuts food benefits by $200 billion. I mean, we have 48 million people in the United States of America who are hungry. I mean, we're the richest country in the history of the world. What the hell is wrong with us? And by the way, that's costly. That impacts healthcare. I toured an
Yep.
emergency room in my district, and and one of the doctors said that pointed out this woman who had come in, an elderly woman who was taking her medication on an empty stomach because she couldn't afford both. I mean, so that we should think of the pain of that woman. But if you're worried only about cost, think of the cost of the emergency room care, of all that needs to be done to help make her well. There's a better way to do this. And we need the larger goal, which is Medicare for all. But in the meantime, we need to win victories, that, are not so large, but can help get us there and can help make our community healthier. So that's my pitch. And again, I appreciate everybody on this call. I do a radio show in Northampton every week, every Thursday morning, and the last question is always the same. Like, what gives you hope? And you know what? What gives me hope is I see a lot of people on this call. And so, I appreciate that.
Do we have time for one more question?
Okay.
Well, there's one here that says, do you have any suggestions as to how mass care can convince pressure the governor, senators, president, and speaker to allow the legislation to pass, a Medicaid for all, universal health care, single payer, to become the law of the state?
Yeah. So I mean, obviously, conversations directly with state legislators and with the governor. But I'm gonna say one thing, and I'm not, in defense of the governor right now. The federal government is cutting every single program you can imagine that goes to the state, Medicaid to other healthcare initiatives, to nutrition programs, even funding for roads and bridges. And so people like me have been calling the governor. I called her the other day because I was concerned that people were losing their SNAP benefits. And there weren't enough people working at DTA to respond. And she said, I'm going to see what I can do. But she said, understand, I'm plugging holes right now. And every time you cut something, someone asks me to plug the hole. And we have limited resources in the state right now. And the stuff I want to do, which is to build on where we are, right now I'm finding I'm plugging up holes because of cuts in the federal government. So the governor and the state legislature, I mean, they have an additional challenge is that they're working with the federal government that they cannot rely on, that is cutting everything. And so it's going to be difficult for them, to find the money, short of finding other ways to raise revenue without cutting something that somebody may think is essential. We have to have the discussions to figure out what is possible in this current budgetary climate. It may not be as much as we want right up all at once, but there's some stuff that's possible. And again, I go back to what I said before, I'm a believer that we need to focus more initially on preventative care, on prevention, on early care, making sure it's more accessible. And I just saw a note that says that the governor may not be familiar with these, with some of the bills that you're talking about. You know what? I mean, there's a lot of good people on this call. Go to her, her town hall. Go to talk to her. Try to make an appointment. Meet with her staff. Maybe you've already done that. But I know this. I've been with this governor, touring food pantries. We've been in some of the most economically challenged communities in my district, and I know she cares. I'm not saying that to make an excuse for it, for, but I'm just simply saying that, we just can't give up. We can't give up on trying to convince her, on trying to educate her and others. And at the same time, we have to change the realities in Washington. I mean, $1 trillion, trillion with a T, cut to Medicaid. I mean, that is enormous. That is enormous. And even if we can get, a commitment to a kind of Medicare for all, timeline, I mean, those cuts in and of themselves are going to have a devastating impact on people in our state, like in the short term. And we got to figure out a way to deal with it. So it's complicated in some respects, more complicated because of this administration, but it's not hopeless. And again, people have to be persistent. Look, we have people who are now for Medicare for all in Congress that a couple of years ago were like, no way. And I don't believe that I convinced them, right? I believe their constituents convinced them. Somebody got to them, that matters to them, and they changed their mind. I mean, that's the deal here. So, look, you have I'm looking at the people that you have on the program today. They're very, I know some of them, and they're very well informed individuals. But I mean, building a grassroots campaign, and being persistent and not giving up, we will get there. Our challenge is how to hurry up getting there. And I'm open to any suggestions. You can text, email me, or whatever, or call my office, or we could talk at a later date. But I appreciate what you're doing. I think it's vital, and I think I think people want this, and we can get there.
Thank you so much, Representative McGovern. We really appreciate your time.
All the best. Thank you.
So, okay, I just want to once again acknowledge our sponsors for the event: Our Revolution Mass, Watertown Democratic Committee, Physicians for a National Health Program, Watertown Citizens for Peace, Justice, and the Environment, Our Bodies, Ourselves, and Watertown Indivisible Progressive. And I do want to acknowledge that Judy Norsigian from Our Bodies, Ourselves is here at the event, as well as Councillor Malachy from the City of Newton, Samantha O'Reilly from Senator Cream's office, and I saw Councillor Caroline Bays from Watertown. And please let me know if there are additional electeds who are participating. So let's move on to, unless there's any other questions or comments, we can move on to the next part of it. So I want to introduce Dr. Gordon Schiff, who's going to be our next panelist. So Dr. Schiff is past president of Physicians for a National Health Program. He worked for 3 decades at Cook County Hospital in Chicago and 2 decades at Brigham and Women's Hospital, fighting for healthcare quality and justice, and is currently a professor of medicine at Harvard Medical School and an associate director at the Brigham Center for Patient Safety and Research. He is the author of more than 250 articles on healthcare quality and safety. So thank you, Dr. Schiff, and welcome.
Thank you. I'm actually here in Washington now, and didn't know if I could be there, but here I am, and we're actually at a patient safety event that's trying to rescue the agency Healthcare for Research and Quality that has a lot to do with producing the data and the ideas to try to make change. Representative McGovern said we need some stories. I'm going to sort of center my talk around a couple of stories. I was asked to talk about what it's like to be a primary care physician and some of the things that are affecting me personally in this current environment. And there's so much to say, so these are just little tiny snippets or slices, but I think I want to just start by talking about just the crisis in primary care. I think this is not something that's new to anybody on this call. Everybody either personally or has a friend or a relative who is unable to find a primary care doctor. And people who have primary care doctors, they're leaving, they're turning over. At my institution, Mass General, well, I just talk about Brigham, actually at Brigham Hospital, in primary care, we have 15,000 people on the waiting list whose doctors have left, are no longer there. So these aren't people who call up on the phone and say, I'd like a doctor at Brigham. These are people who we are already caring for but we have nowhere to reassign them as their doctors have left. Why are doctors leaving? They're frustrated, they're burned out.
Mhm.
Obviously, people are getting old, they're retiring. New doctors, we don't have enough young doctors coming into primary care. A couple of weeks ago, we had the match in family medicine, primary care, especially the leading one, uh, that's devoted to primary care. And the half the positions didn't fill. The doctors chose not to go into primary care. So why is this? I think people are seeing the frustration, the burnout, the lack of support. If we had a different kind of country, we could really reallocate making primary care priority. There's 100 reasons why primary care leads to better outcomes, keep less expense. Lots of research has shown this. In our country, depending on how you define it, somewhere between 12 and 30% of doctors are primary care. That leaves, 70 to 80% specialists. In Canada, it's 50-50. Okay. Other countries have different ratios, but these are policy questions that we can make primary care work and desirable and not a source of burnout, but a source of joy in working with patients. Now, one of the themes I'd like to say is we sort of have to be united or get united. And we're going to talk about United Healthcare in the next couple of examples. But one of the things that's happening in primary care is that patients and doctors and clinicians are becoming adversaries rather than working together. So we're frustrated that we don't have enough time. Patients are angry that they're being rushed through. They can't get appointments. They're being charged huge copays. We're having to spend much of our time in paperwork and prior
Mhm.
authorizations. We can't get patients the things they want. So we're creating a situation where we're really becoming alienated and adversarial with patients rather than getting together with patients to have relationships rather than transactions. A longer discussion was the whole topic of moral injury. Physicians for National Health Program just produced a report on this problem. It's not just burnout and stress, it's actually people's values of really wanting to care for patients are being superseded by a health system that says what matters more is throughput, profit, market relationships. So let me give you the two examples that I think really illustrate some of the key principles of what we're trying to change here. And for the first one, I have to read from my, see if I can get it now. Yeah, it came back. This was from my, this is called your Epic inbox. This is the message from the patient back and forth. We have to communicate with the patients. And I'll just, well, the context of this is that United Healthcare, Mass General Brigham and the insurers have decided that they can't negotiate an agreement for people to be able to continue to get Medicare Advantage patients get primary care. So 19,000 patients were kicked out of our primary care clinics and network January 1. So here's one of them. He's writing to our practice manager and saying, please help me. I was told to go somewhere else. I can't find another doctor. And here's what we've written back. So actually, these people are writing this for me, and I'm practice manager, the Gen Center. Let's see, work closely with Dr. Schiff. Apologies, you find yourself in this situation. Decision that regarding plan contracting status of our Brigham PCPs no longer being in network with Medicare Advantage, HMOs, and United that came to the top of the organization. We currently would want to keep you as a patient so you're able to review insurance plans, but there's no way to do so, and we cannot continue to see you in this HMO plan that you have. Our organization created a website below and a call center to be able to speak with patients, basically tell them exactly what I'm telling you here, and that there are other patients being affected this as well. Please, we encourage you to go to the website to get this information. This is the Medicare Advantage Change website. So, you could say, well, this is just some small little piece, but what it is a window into a way that a healthcare system is working. This whole idea with single pay, there's no such thing as in network, out of network. First of all, there's no such thing as people being insured and uninsured. The eligibility criteria is not where you work or what disease you have. It's being born and the disenrollment criteria, this man's been disenrolled from our care, is dying, is death. So otherwise, you're covered your entire life. And so let me talk about one primary care principle, which is continuity of care, knowing our patients, being able to make the correct diagnosis because we know our patients and we can talk to them. We build trusting relationships. These are all being eroded through things such as what I just read to you. You can imagine the time and effort and waste. And by the way, this patient is very ill patient, mentally ill and physically ill. He's got a lot of problems. It took me the better part of a year with multiple visits to get to know him. And now here he's off, at the best, he's going to find a new doctor, but so far he's tried and not been able to. Let me talk about another thing going on with United Healthcare. And I think when I came to the forum before, I brought a few of these, but I've gotten literally, I can't estimate, 50, 80, 100 of these things in the mail. You can see I haven't even opened this because there's no point. This is the health and wellness prevention information from a United Healthcare patient. A nurse went out to this patient's house and visited her. Is it her or him? Actually, the name I can't see if I open it. So a nurse went out there, and boy, that sounds great. The insurance companies really, they care about their patients. They're our friends. They're helping us do home health visits in the community. Well, none of the above. What is going on here? Maybe if we were interacting in an audience here, I'd let you tell me, but it took me a while to kind of get it. Mostly, I just thought this was a lot of paper where they list the patient's medicine, which I already know, and they list the patient's problems and check a lot of boxes. And it seemed kind of just a meaningless waste of paper. And I thought they were just trying to justify their existence as middlemen in our healthcare system. But I was wrong. The real reason people are going out for these visits is to increase the number of billable coded diagnoses. And so there's a wonderful article in the American Prospect, but we hear all these stories about what these nurses are doing. There's a nurse, and she talks about doing QuantaFlo. Now, I actually had not heard about this test. We people who have severe peripheral artery disease, we send for what we call vascular Doppler blood flow studies. But this is a portable version of that studies that I do when I'm worrying about a blood clot or arterial blockage in a patient's legs. So these nurses carry this machine around with them, and they do it on every patient. So there's no evidence that screening asymptomatic patients for peripheral artery disease is of any benefit, okay? But it turns out it is benefit for United Healthcare, because if you can add PAD, peripheral artery disease, to the list of diagnoses, then they get, instead of $6,000 a year per patient, they can get $8,000 or $10,000 a year, especially if you start adding these things up. Okay, so these home visits, and here's the irony. One of my patients who I tried desperately, her husband got admitted to the hospital. She has dementia. He cares for her day and night. There's nobody to take care of her. I wanted a home health nurse to just come, a visiting nurse, to see her maybe a few hours a day or get an aid. And this patient said, no, we can't do it. We won't cover it. We don't have the staff. The next week, I got one of these home health nurse, I guess you would just call it fake health visits, on that same very patient who we couldn't get a real nurse. I mean, these are real nurses, but a real visit to help the patient. So a lot of these diagnoses, by the way, people who've done research, are diagnoses that they've never received care for the whole year. So they find out this person has coronary heart disease, but they've never had any medical care for heart disease. So anyway, a lot of money being ripped off. The other thing that there's good data. Over a period, I have to keep looking, $547 billion extra money for the Medicare managed care. Medicare used to be a public plan. We want Medicare for all. It's been hijacked by these private insurers. But $547 billion, which could have gone for healthcare, has gone for increased coding, as I just told you, as well as favorable selection. So you can make money in managed care by getting well people and avoiding sick people. So, and then the ones you have, you try to make them look sicker. So they're interested in sick people on paper, but not really sick people to take care of. And there's a lot of money being made where we're paying for patients that really have no need for care and that never had any expenses. Of course, that's the healthy 65-year-old on Medicare Advantage. When you're 85 or 90, then those people need health care, and often they end up leaving the plan. So the next example I want to talk about, so I think you have an understanding of how those two things illustrate some of the problems of a market-driven for-profit system. We have a problem with healthcare costs in the United States, okay? And of course, the thing is, and as you know, it costs twice as much as any other country. There's a lot of money. Some
Yeah.
of it's going to profits and administrative cost and waste and gaming and all sorts of things that add not only to wasteful money, but complexity, confusion to patients and patient harm.
Yeah.
But what I want to make, and I guess I'll make this the final point, is
Yeah.
that there's no way that the insurance companies have to do this stuff because they have no other way of making money and holding down costs. So things like prior authorization, which turns out I just saw a recent poll, it's the number one frustration in addition to lack of access of care, that people are having delayed or denied care because of prior authorization. This is something a doctor writes. I say this person needs this drug for asthma. They can't get it because they don't have prior authorization. Okay. And so there's legislation, and the insurance companies are trying to, make some reforms. I just saw that it was an 11% decrease in prior authorizations by the insurance companies last year. So people, I guess, are supposed to be applauding that. I would say that's laughable, and that's public relations mainly, to the fact that it consumes an enormous amount of time in physicians' offices, clinicians spending time on the phone, arguing for their patients. These are secret algorithms, by the way. I mean, if you just told me this is the criteria for somebody to have this asthma medicine, and I'll just tell you honestly, whether they meet that criteria or not, I don't want to give somebody a drug that's not indicated, for example, or a test that's not indicated. But these are secret proprietary algorithms because this is their secret sauce of these private for-profit companies.
Right.
So how do these save money? You displace costs to other people. You avoid taking care of the sick people. That doesn't save money. That just transfers that, shifts costs to somebody else. How do you save money? You put in big copays and deductibles. They work, by the
Mhm.
way. People stay home. Although there's no
Right.
selectivity, people stay home if they're sick or if they're well, equally so. So they don't really select the well from the sick. But the kinds of things that people are experiencing as frustrations are actually, I would call it a futile attempt of ineffective attempt to try to hold down costs. If we had single payer, we have much more effective ways of doing that. And I know we're out of time.
Yes.
You just list a few of them, or we can maybe talk about them later in the Q&A. But those are, as you go and see the problems, I want you to put on a set of glasses and lenses and see these problems in the light of what single payer would be doing and how things would be different.
Great. Thank you so much, Dr. Schiff. We will have Q&A at the when we're done with the panelists. So we're on a tight schedule. I just want to remind people to please put your questions in the chat, and hopefully we can get to them in the Q&A. So our next panelist is John Weissman. Mr. Weissman is a retired letter carrier, a local union president, with Jobs with Justice, and a labor community organizer in Western Massachusetts. In 2017, he co-founded Western Mass Medicare for All, and he represents it on the board at MassCare, the Massachusetts Campaign for Single-Payer Healthcare as well. He is also the president of the Universal Healthcare Education Fund. So thank you, Mr. Weissman, for being here this evening.
Thank you, Allison. Thank you all for coming tonight. One of my, I do a lot of volunteering at MassCare, and but one of my favorite roles there is to make sure that folks like you get the answers you need to be organizers. So I want to focus on the bill that solves this problem on the financing front. And give you a certain amount of information, see what your questions are that's left. In the chat, a couple of links. So our legislation is called an Act Establishing Medicare for All in Massachusetts. And you've got the links to read the bill yourself. I think it's a great read. You'll find that there's a section 2, I think it is, that basically works like a leaflet to tell you all the talking points of a single payer system. So, of course, we can come back to the fact that we have a struggle in the State House to get this thing passed. But let's just understand for a bit what we're talking about. So, improved Medicare for all or single payer health care, these are specific versions of paying for universal health care. They're a subset of universal health care that eliminates all financial disincentives to seeking care and all financial disincentives to providing care. So it's a single consolidated nonprofit system devoted to healthcare that is devoted to paying for care, not insurance with a profit incentive to deny paying for care. So for our bill to qualify as a single payer bill, it has to provide everyone with publicly financed healthcare with no out-of-pocket costs. It covers all medically necessary healthcare at any licensed provider of our choice, including hospital care, outpatient care, reproductive care, dental, vision, nursing, long-term care. There should be nothing under this kind of a system that a provider orders that isn't covered. It covers all residents of Massachusetts and all non-residents who work here 20 hours a week or more. You could play with that side of the equation and cover even more people. But for now, the goal is at least to cover all residents and people who rely on Massachusetts for their livelihood. It empowers the Massachusetts Healthcare Trust to negotiate with drug companies and other manufacturers. It's going to have the bargaining power of the largest pool you can imagine of clients, of customers, of forming a healthcare trust of people. So it's going to drive prices down at that end. Patients, doctors, and other providers get to make all the medical decisions. No middlemen. The Massachusetts Healthcare Trust just pays the bill. The trust is funded by consolidating all federal and state healthcare spending in Massachusetts. That's Medicare, Medicaid, and other programs. That's about 2/3 of the revenue. And replacing, the other third is about replacing all the premiums and out-of-pocket costs that we are currently spending, co-pays, deductibles, co-insurance, all that stuff, with significantly lower taxes. So obviously there's some politics there when you talk taxes and you talk federal money. We can come back to that if you want. Replacing all premiums, by the way, we say we're replacing all premiums, all health insurance premiums. Remember, that includes replacing the health insurance premiums that are part of auto, homeowners, other property insurance, and workers' injury compensation. And just so you know, we can get into the details about the tax structure, but it is way better than the proportion of income. First of all, is scaled to your income. Currently in any typical company that offers a health plan, the premium is the same for the secretary as it is for the CEO. So of course, it's a greater percentage on the secretary. So we instead use a percentage of income, 2.5% on wages and salaries, 10% on self-employed income. And there's certain non-payroll income at 10%. What this comes out to is a savings for 98% of the residents of Massachusetts. Though that other 2%, by the way, is not going to suffer by a small increase. But if they're paying now, if the CEO in that 2% is paying what the secretary is paying, they must pay more for it to be equitable and fair.
Mhm.
So the bottom line is, by the way, all these taxes have a $20,000 exemption. So the individual taxpayer also, is getting $20,000 per taxpayer, but then also the employer on the payroll tax paying 7.5 or 8%. They're also getting a 20%, a $20,000 exemption just because every taxpayer gets one. Now, you may have heard that we have done an economic analysis. We always ask a progressive, pro-single payer economists to tell us what the budget would be of this trust fund. It's always based on current spending. Then they squeeze out waste, fraud, profit, abuse, all this shit the time, that is not spent on healthcare. And then we realize that there's not enough healthcare in the state, so we add back some of that savings. And we come up with a reduction of current spending of 30%. That goes back into the Massachusetts economy. That's stimulating the economy. That's not being used for healthcare. The gross savings before that was something like almost 50%. So we had to use some of that money for healthcare. But still, look at the billions that are saved. That's $37 billion. So then you can go to our website, masscare.org, very easy to find, and see some of the math. And you can also go there and you can see the math, particularly for your city or town. There's a movement now in order to drive cities and towns into bankruptcy on healthcare. There's a movement by the insurance companies, and then there's a counter movement by the cities and towns, I hope, to get single payer healthcare that'll solve the problem, not just for them as employers, but also for the rest of the employers. So I want to leave it there, make sure there's time for Q&A. Thank you.
Great. Thank you, Mr. Weissman. So we will go on to our final panelist, and then we will do the question and answer to the time. So please add your questions to the chat. So I'd like to introduce Heather Clark. Ms. Clark is a founding member of South Shore Medicare for All, the South Shore hub for MassCare. She led a successful local resolution endorsing Medicare for All by the town of Scituate. So welcome, Ms. Clark.
Thanks, Allison. And
Yep.
It's been great to be on the panel with so many wonderful people. I want to talk to the folks in the audience tonight who are not physicians, not politicians, not economists or scholars, just people like me, who have no particular background in, healthcare economics, but who can and very much do the grassroots work of organizing here. If you're a person who has experience of our healthcare system and experience of our health insurance system, you are 75% of the way there. I mean, you don't have to be an expert, but you know what the problems are. You have your own stories to tell, and people will tell you their stories when you talk to them about this topic. So when the masscare.org website is a wonderful resource. John mentioned it, others mentioned it. You can read the bill, you can look at frequently asked questions. There are all sorts of ways to look at this information that's very comprehensible. I was a terrible math student and it all makes sense to me. So when I talk to voters, whether we're, knocking doors to educate voters about, a local non-binding ballot initiative, which MassCare has done, dozens of times in the state. When I'm collecting signatures on a petition, in a parking lot, if I'm in a forum, talking to folks, in all of those situations, when I talk to people about this concept as well as about the bill that is existing in Massachusetts, they are supportive and shocked. They're supportive conceptually, and increasingly people are coming to the conclusion that single payer is really not just the best way forward, the only way forward. But many of them have not heard about this bill that has been introduced in one form or another for a couple of decades in the Massachusetts legislature, only to just die session after session. So, I think Congressman McGovern said it best. It's like, if they don't hear from you, they, think everything's okay and focus on other things. So, everybody here can make a 2-minute phone call. You're not going to have to talk to anyone. You're going to get a message machine anyway, and simply weigh in and say why you support this and that you expect your representatives to support it too. One of the things that I hear from folks that I have to admit is the most discouraging thing I hear, which is, it goes something like, I absolutely support single payer, improved Medicare for all. I'm there, but it'll never happen. And that's like a knife to the heart, right? It's like, it won't happen if people don't believe it will happen enough to, make a call or, talk to their neighbors about it. So, if there's anything that I can impress upon folks, you don't need any skills. You don't have to know the bill inside out. You don't have to, be expert. You don't even have to be able to answer questions that people might have. In fact, it's a great opportunity to say to someone, give me your email or give me your number and I'll find that answer for you and I'll get back to you. And that's a great way to, spread information, but to build some real trust with voters and let them hear about MassCare. So, finally, sort of the last thing that I want to talk about is, of course, affordability, right? Affordability is on everyone's mind. Everybody is getting crushed under these escalating insurance costs. Towns and cities are panicking. I mean, there's right here in the South Shore, one of the nearby towns, there's been a rash of resignations from their select board and a recall effort. And I mean, it's getting ugly. It's so frustrating to hear all of our political leaders in the state, from the top on down to communities, talk about the problem when the solution is already sitting right there in the legislature. So, the perennial question that, we've been hearing for years about this is, sounds great, but how do we pay for it? So if there's one message that I can leave with everyone here, with everyone who has any kind of platform or influence, it's that Medicare for all doesn't cost money, it saves money, right? If we can it doesn't cost money, it saves money. And if we can just chant that like a mantra, I'm hoping that we can begin to actually push back against the disinformation that is being put out there by insurance companies and every other profiteer in our system, and really change the terms of the debate, right? Because they've managed to get that question out into everybody's brain. And we need to, the first thing we need to say to push back is Medicare for all doesn't cost money, it saves money. So I'm hoping that folks will, if you haven't seen it, take a look at the MassCare website. Familiarize yourself with some of the facts, the figures, and the positions, the ways in which questions can be addressed, but mostly get involved in your local hub. If you go on the website, you can look at the different hubs across the state. South Shore is one here. There's one on the North Shore. Western Mass Medicare for All is a crackerjack organization. Each of these hubs is growing. I'm seeing a lot more people showing up at our, monthly Zooms. I'm seeing new faces. I'm getting a sense in talking to voters that they are more aware of single payer. As Representative McGovern said, some 70% of people support it, and they know enough about it to support it. So you, in getting involved in this movement, don't have to know any more than the people you talk to, because you can find out what you need to find out. But everybody already knows this crisis is unsustainable, and you already know the basics to be able to talk to your neighbors, talk to your friends, and really get involved. That's it.
Hey, thank you so much, Ms. Clark. So now we are going to open up the questions for everyone, but I also wanted to give our panelists an opportunity to take a minute to comment on anything the other panelists have said, or something that struck you, or a question that you may have. If you would like to have that opportunity, we can do that as well. I was struck by Virginia in the chat, who's saying we're already paying for it, but we're not getting what we paid for because we're paying the wrong people. I mean, that's absolutely right. And I also just wanted to tell a little bit about how I got involved in this Medicare for All and the insurance issue. We had a ballot question in the 10th Middlesex, which is where I live, which is Newton, Waltham, and Watertown. And it asked voters, shall the representative of this district support a Medicare for All single payer system? And it passed over 68%. And I was astounded at that amount, because there's parts of it that are quite conservative. And then I saw there were a number of other communities where it also passed overwhelmingly. Some were as high as 70%. And I realized the problem here is the cost of healthcare is just hammering people. And as a city councilor in Newton, I saw it crushing our budget, and we are struggling to pay for our schools. And just last week, the Wall Street Journal had a story about South Hadley, whose healthcare costs went up 47%, and they tried to do an override, which failed. This means towns are not going to be able to afford their schools, or critical services are going to be cut, including police and public safety. And that's really one of the big concerns that I have. So if the three of you have no questions for each other, we can go back to the chat and see if our participants would like to ask some questions.
Okay.
I would just make one brief comment. I think if we're going to win this politically, and I really appreciate the last talk about really thinking smart strategically. One of the things about single payer is people really can understand it. It's really quite simple. The Democrats shut down the government over subsidies for the marketplace plans of the ACA. I can't even pronounce it. Seems like an arcane thing. Of course, people are going to be hit very hard with this and realize what this means. But talk about nibbling around the margins and the edges. We really need something that looks at the bigger picture and simplifies the issues for people and really makes them convincing. Quentin Young used to say incrementalism, which I think we'll hear from our political friends, compromise. Incrementalism isn't the solution, it's the problem. All these complex Rube Goldberg, child's health for this and an ACA subsidy for that are, you could say well-meaning attempts. They're really compromising with vested interests to try to keep the current system intact with some little improvement around the margin. So I think I think we should think about really sustainable, actual solutions that are going to really make it work.
Allison,
Yes.
to your point about the ballot question, I put a link to a spreadsheet that counts the all the ballot questions that Mass Care has run and also has some information about others. And the ones that Mass Care has run, 68 of them since 1998, is it? The average is 68% of Massachusetts residents voting for single payer. So a lot of people like to say, well, you've won the policy. You won the, people understand it, people get it. You've won the policy. Why doesn't the legislature pass it? And that's probably the more important question, because you can find legislators who are doing nothing for it, nothing. They're identified as middle of the road or not on our board, or not on board with it. But they still understand that it's going to save money, that it's going to save not money, it's going to save billions. And they have to pass a budget every year, and it's going to save that money. So I am not sure that at this stage in the history that the problem is education as much as vested interest in these legislators.
Mm.
And people who have been fostering, and wealthy people who've been fostering and sponsoring these legislators, they don't just give them money. They become comrades. You got to think of them as recruiting. Once you get elected, it's open season for the rich to try to recruit you to their world. It's not just giving you money for your reelection. If it was just giving you money for your reelection, you don't need that money to run on single payer. We've won the policy. People will vote for you if you will only run on single payer. So that's not the deal. The deal is something else. They really have bought into, you could call it class solidarity with their benefactors. It's kind of a Stockholm syndrome thing. And
Yeah.
if you identify your legislator as a captive of industry, a captive of big business, a captive of the rich, and you can't do an intervention, right? You have to replace them. Once they get out of that job, they'll come home. Their mind will clear. So
With you, John.
I know you are. So we will either convince the ones that are incumbents or replace them before we actually pass the bill in the legislature. Now, that itself looks daunting. Both of those sides of the equation are very hard work. So let's make sure we also go away from this thinking we might have to run a ballot question, a statewide binding ballot question that forces it on both our reluctant comrades and our anti folks and our liberals.
Yeah.
So
Although
I
we've
think
had some ballot questions that have passed resoundingly that are still haven't been acted on.
yeah, you'll always have the problem be sent back to the legislature. The legislature
Yeah.
always gets to then mangle whatever you do with the ballot. But that's not the issue right now, because if they are convinced by their voters, one way or another, run a non-binding, do a signature gathering for a binding, an uprising of the people, then they get the cover they need to pass the bill. And so when we get to that point, which is it's the largest movement in the history of Massachusetts. When we get to that point, I just want to prepare us that they're going to ask us to compromise. They're going to ask us to put copays in. They're going to ask us to let private insurance have a piece of the pie. And then we have to just stand fast. We have to know that, like Jim McGovern said, we have the power and we don't have to yield it.
There's a lot of questions in the chat. Should we get to them?
Yes. I just wanted to ask Heather if she wanted to make a quick comment before we move to the questions, because You look like you were ready to, but you good? Okay. And I just wanted to ask the person who raised their hand, Hank, to please put your question in the chat. Yes, let's go to the questions, please.
So one is, why, John, do you think that the governor is so against single payer? I mean, you just
Yeah,
made a statement about the electoral issue, but people want to know why she's
yeah, and
not on our
I did
side.
reply to that. I think
Just
everyone
tell the
can.
rest of the world here.
Yeah, I wondered if that was a private reply. I don't think it was. But the bottom line is it's because that's what she says. She's not against, she's not working against, she's just not going to make it her cause. And she tells
Okay.
people that. She's very honest. Um,
Okay.
so I mean, there's not much more we can do but get the legislature to send it to her desk. She'll either sign it or veto it, and they can override the veto. If you got a legislature that can send it to her desk, you've got a legislature that will override her veto. Let's not forget that one of the most progressive presidents in the United States, threatened to veto a single payer bill. And
That,
it's just the case that you have with these executives that they are different. That's why I'd
that's
like to see it passed either at the ballot box or in the legislature and not rely on the governor.
okay. So someone asks what you think, what any of you feel would happen. People seem to be in favor of single payer, but they're troubled by what will happen if there'll be a transition and people will have gaps in services, or there'll be other problems when if we're so lucky to actually start implementing single payer. Any thoughts on that?
Well, when I saw the question, I thought of an answer, but I'd like to see if others want to answer too.
Okay.
I can jump in
Heather,
a
go
little
ahead.
bit, even though I'm
Yeah.
not, I'm not expert. There is language in the bill that refers specifically to a just transition. So people who perhaps, lose jobs or something like this, there's funding set aside for retraining and such. So that's one part. The other thing that I just want to put out there, and I've just been thinking about this myself, but we would not be starting from scratch. Massachusetts has been building towards, universal coverage, which we have. We have now de facto universal coverage. 98% of us have insurance. The problem is we can't afford to use it. The problem is that costs keep going through the roof. But in any case, in order to get us to this point, we have infrastructures, we have mass health, we have, entities that supervise and administer and such. And I just think that we are further ahead than many other states to be able to make this transition. We all remember when, Obamacare, they flicked the switch on it and the computer didn't work, and that was really ugly. Maybe that's what people are still remembering. But, we have infrastructure, we have talent, we have experience doing a higher level of publicly funded healthcare here in the States. So I think that I have faith that a transition would be about as smooth as it could be in a big system change like this.
Okay.
Okay.
I agree with that. I think the expertise that we already have can be found. A lot of it can be found in the workforce at Mass Health. A lot of it is actually in the workforce of the insurance industry, of big hospitals and big medical practices. We've got the people, we've got the expertise. One thing to remember is that Medicare was implemented in 12 months. And it was not a problem. And then they gave the first Medicare card to Harry Truman. And people
Right.
know how to do this. And if they don't know how to do it in the United States, they can always ask some of the other
Can I
countries.
take a crack at this? I was just looking at some slides I put together. Some we touched on when we last talked, but some I've developed more. Everyone's saying we're very mindful of a transition period. You know, and I think these you have to look at something that's an excuse for not doing something, or a serious part of a transition where there's a will, there's a way. So if I can just bring up I just have this on a slide here. I'm not going
No.
to share it with you. These are all the things that disappear under single payer. Health insurance marketplace exchange sales forces, the annual special enrollment period, marketplace new and special enrollment pre-enrollment verification process, metal tiers, bronze, silver, gold, children's health program, transitional reinsurance program, reinsurance risk corridors. So that's one slide. I have an open enrollment period, dual eligible program in patients, premium stabilization program, exclusive provider organizations, and benefit year risk reduction. I could go on and on. So I guess it will be tragic that all these complicated things are not going to be here anymore, and people will lose their jobs, I guess, and we'll have to find jobs. But as far as I'm seeing, it's a good riddance to all these crazy, complicated things we have in our system. So we should
Yeah,
just see clearly what we are losing and what we're gaining.
right. So we have a few more questions, Marge.
We
Yeah,
do.
yeah,
One is about labor and let me find it again. What the labor unions, um, sorry, how does labor view their privileged position after having good health insurance, instead having to get into the same single-payer universal healthcare insurance pool as the non-unionized? I don't understand. Does
yeah.
not labor see it better for them to negotiate for wages, work conditions, and retirement and leave healthcare benefits aside? I mean, I think we should talk about labor's issue in this because we just heard at a visit with Ben Weber that, and with the mayor, that Boston unions are being blamed for, have reducing a lot of social programs because their health insurance needs are so high. So if you could just take that and think about the panel, though we lost Heather. I don't know where she is.
Oh, okay.
Heather, are you here?
She just
She
came
just
back.
came back,
Okay.
just a minute. Okay.
Okay, great. People, I think they're asking, I don't know if they're asking what the labor union position should be on this, or what are the right way of thinking about this in terms of labor.
I posted in the chat the
Well, we're
page that
talking.
lists all our coalition members. A huge proportion of them are labor unions, and the overwhelming majority of unionized workers in Massachusetts belong to one of those unions. We do not have the problem here that they have in California and New York State. And so what we're talking now with the unions about, like SEIU 509, Service Employees 509, represents most of the state employees that will be affected by our plan. So we just had a meeting with them about figuring out what it looks like for their workers and how we defend their workers in the transition. That's where the majority of the labor movement is at. That doesn't mean that a minority isn't feeling any kind of threat, but they're also feeling a lot of pressure that they have to give back stuff at the bargaining table because of healthcare.
Got it. There's a question for Gordy about what do physicians, why is there the reduced number of primary care, but also do you think specialist physicians are not interested in single payer because it will reduce their salaries?
Yeah, I'm kind of busy typing in all these things just to make a point, but let me of course answer this question. There's one more whole set of things that disappear. But mainly pre-existing conditions disappear, and again, good riddance to that whole concept that because somebody's
So,
sick.
so the question
But
is,
let me answer your question.
yeah,
So specialists have historically been less in favor of single payer than primary care doctors. However, some specialists, for example, psychiatrists, have been very supportive of single payer over the years, and they're heavily represented in. I think emergency room doctors increasingly are seeing the need for single payer. The ERs are being flooded by people without insurance, without primary care as a result of a fragmented system. Oncologists are now seeing the American Cancer Society has a whole section of their webpage about, they call it financial toxicity, right? You know, we talk about toxicity from chemotherapy, people lose their hair, they throw up, but this is financial toxicity. Often people are going broke just because they have cancer, which, as we would all agree, is no reason to make someone go bankrupt. So first of all, I think there are growing openings. Second, yes, many specialties have kind of a good deal, and they think that that status quo would be disrupted. Perhaps it would be. Many of them earn very big salaries and disproportionate to what primary care doctors. So maybe there would be a leveling. But one would hope that we could catalyze some of the real reasons people became physicians, and also think about, and this is the final one. It was mentioned I was a past president of PNHP. I kind of even forgot about it. It was 1994. It was sort of ancient history. That year, the American College of Surgeons appointed a task force to say, what's the best health reform? This is the Clinton health reform debate. And this committee seriously looked at all the options and proposals, and they came back and said, you know what? Single payer would actually be best. All our patients would have their bills paid, and we wouldn't have to worry about this. And of course, this committee, which was not a hand-picked, left-wing committee or anything, it was just people honestly looking at what would be best for surgeons. And of course, the surgeons who were more conservative historically overruled this, and that was the end of that support for single payer from the surgeons. But the internists have, the American College of Physicians has supported. So there's surprising opportunities to really leverage some of these things I'm raising. I'm doing this very quickly, but yeah.
Yeah, we
Okay.
had a discussion with Wayne Altman about primary care. It was very good. And there's 3 good bills in the state that we should be looking at too, that might help at least in the short term. So let's go on to the next question.
Marge, if I
Oh.
could just add one little tidbit to what Gordon just said. There's a sea change going on now with doctors in that, almost none of them are in private practice. They are, part of these large practices, which are in turn being acquired by private equity and corporate interests. And so now even specialists are just wage slaves. I mean, they're better compensated than many other professionals, but the pressure is on now as medical, as the financialization of and consolidation of medical practices just picks up steam. Right here in Massachusetts, Atrius Health, which I assume is the largest physician practice in the state, certainly, we all go to them here in Eastern Massachusetts. They are owned by Optum, which is owned by United Health. All those doctors work for that insurer, right? And that insurer is not paying them, top dollar, that they might have gotten as, a specialist in the private market. So, the circumstances are changing such that, even specialists are losing the autonomy that they might have had.
There's there's a couple of discussions about nearby states and the ballots that they've done. One, that they've done a ballot in Maine or are working to get a ballot in Maine. And the second, like if anybody had any thoughts about why single payer wasn't implemented in Vermont.
Yeah. John, can you speak to that?
So
That
in the
question?
chat, I put a link to our case study of Vermont. Vermont was
Okay.
entirely a political problem. The governor narrowly lost re-election, and that was partly because of his endorsement of single payer, and the rich didn't like it. The social forces there are a little bit different, smaller and whatever. They had gotten the bill passed, though, and it's still on the books. So the issue in Vermont is not about passage. It is about financing. And one of these days you're going to see they're just going to write they have to write two bills in Vermont. They have to write a bill that establishes what we call the trust. I forget what they call it, Vermont Care or something. And then they have to write a second bill that finances the trust. And they didn't write that. So they didn't pass it. So in Massachusetts, we don't do it that way. By our Constitution, we write one bill, sets up the trust, and tells the people how it's going to be paid for. So if someone's going to try to go after it as, oh, tax increase, biggest tax increase in the history and all that shit like they tried in Vermont, it ain't going to work because we've already shown our work. We've already put it in the bill. We've already done the calculation, and it's the biggest tax decrease in the history of the state.
How will our work related to single payer ensure that women have reproductive justice? How will we be sure that local or federal or other statewide issues related to, abortion services? Massachusetts right now is very supportive of abortion services nationally. They've protected physicians, etc. But you can think that there are other issues that might arise. That how are we going to be assured that the people who are in need of services are actually the ones determining those services?
Heather, Gore, do you want to take this?
My understanding is that abortion is explicitly mentioned in the bill, and so it is protected, by the passage of the bill. I mean, can abortion services come under attack? Obviously, we've watched it happen, and I think that, but I don't think that single payer puts any of us at any more or less, well, actually probably less risk, but we are not at more political risk of losing the right to choose by virtue of single payer. And frankly, I think if the entire population is involved in, this one system, that, the democratic interests of the majority are going to prevail. That's my take on it. But I also never thought we'd overturn Roe v. Wade. So can't
Right.
say.
The bill has to include abortion. It has to include reproductive care comprehensively because it's already the law of the land in Massachusetts.
Right.
So putting it in there, it strengthens the other law, but really it comes down to the power of the people in this kind of a system versus the power of corporations.
Right.
Our economist Auden Cote-LaRue likes to say when he's talking, and he wound up being able to say this to the Boston Globe editorial board. The different system, it may have its struggles, it may have its problems, but at least it's owned by the people. They get to say what they want covered.
Oh, it's an important point. Yeah, that was the point I was asking about. So there's a little bit of back and forth with John in the chat about legal implications that people will fight against it if we do pass it legally. But
you got to anticipate that maybe someone will sue you. But right now, I would be more worried that someone would try to litigate a statewide ballot question. I can't be worried about if the legislature passes the bill and the governor signs it. I'm not worried as much about that.
Okay. All right. Here's Hank's question. I hadn't seen it. Because we will be outspent by millions of dollars, we will have to do it as a year-long teaching event, much like the civil rights teach-ins. Low-cost Mamdani type Instagram message campaign to start. We will have to educate the public and concerned decision makers about what the advantage is for all for single payer. So that's his comment. Anybody want to respond to that?
I'd like to invite him to join the movement. By all means.
Yeah.
We want
I think he is. He's here. He's here.
I guess
Yeah.
what I would say is single payer is not the final solution. It's a framework and it's an ongoing struggle to maintain these services. Okay. It really creates a system where everybody is in. So actually, one of the things that hopefully will drive quality and reproductive rights and other things that people need is the fact that people. The idea is not, I'm not, going to go be able to go out privately to get this. I'm part of this system, and I need to fight to make sure this system provides for my needs. So it really, I think, enables. It doesn't guarantee a democratic outcome that we would want, but I think our struggles in some ways just begin to get the things we need. But I think I can't emphasize enough. It was one of our quality principles. We did a paper for PNHP on quality, but when you put everybody in the same system, then it's not like you have Medicaid for poor people and then you have another system for rich people. This is an equalizer in terms of driving improved quality because people who are empowered are part of that same system. Social Security, many lessons with Social Security, but it's a universal benefit, not something for poor people on the side.
So there's a couple of comments about how we are so right about single payer. It's just that the people with the money and the legislators keep ignoring it. And then there's a question about fraud and how that could be eliminated with a single payer system.
It's much easier to detect fraud when you have a single unified database. So that's it doesn't prevent bad. If you build a system based on profit and people trying to corrupt this for their own means, and really that being the driver of the system, then you're going to see a lot of that. If we really build it as a public system where there's transparency, accountability, there's the ability to monitor what people are billing, where there's public guidelines. So there's not secret guidelines about whether somebody's doing a test at the procedure they shouldn't do. We would be deciding this scientifically, collectively.
And if the system is public, it's transparent, right?
Yeah.
And so, anybody can be going and looking, obviously not at people's private medical information, but the data is going to be available. And, one of the other benefits of that, in addition to being able to sort of, sniff out fraud and see things that don't fit, quite, is that there are enormous, huge economic benefits, but enormous public health benefits as well. If you just think about something like food as medicine, as Representative McGovern was mentioning, we all know on an intuitive level, and there are probably studies out there too, that say, oh, if you eat a healthy diet, you'll spend less on healthcare, right? Makes sense. But in our current scattered system, all of that data exists in all different places, and people, receive care that's paid for by different payers throughout the course of their life. You can't, there's apples and oranges bouncing all over the place. If you've got a single payer, you can look at where a cancer cluster is, or, some issue with childhood obesity, or, you can actually look at the data based on the payments, right? Follow the money. Where are we spending the money? So that the public can actually see the impact of investments of certain types in other areas, whether it's housing, nutrition, what have you. And they can actually watch that information have an impact because we have a singular system that is accessible and analyzable and all residing in one place. So it just makes sense to me that we're going to be able to advance public health with that enormous transparent database, at our fingertips.
Yeah.
Reed,
So
no more questions. No more
let me answer
questions.
technical.
No more questions. That's it.
Yeah, I'm sorry, I have to jump in because we are coming to the end of our time. And I think that what we have here is just the beginning, not the end of this. Has been a great discussion, and I want to thank all the panelists and everyone who attended. And we will get back to you with questions that didn't fully get answered. I mean, it's such a huge topic. We really just started here, and we hope to continue the discussion. I want to make sure that people know you can see the Mass Care website in the chat. John Weissman just posted the part on the economic analysis, but there's a lot of information on that website that for you to peruse. So I hope that we can do this again. I think this is a very productive discussion, and we need to continue the hard work. So thank you all for coming.
Hey,
Thank
I
you.
wanted to say something. I'm my mom's son, William Bohanna. What?
Thank you, Middlesex 10 Hub.
Yeah. Oh, thank you, John. This has been a great discussion. So we'll see you all soon. Thank you for everyone's participation. Have a great night.
Bye.